Welcome to the Grand Rounds. My name is Michael Green, and I'll be introducing our speakers for today, both of whom are close colleagues of mine. Yvonne Yang is an assistant clinical professor of psychiatry at UCLA. She's the chief of the psychosis section at the VA Greater Los Angeles, and she directs the Thoughts and Perceptions Clinic there. She also, for those of you involved here on the UCLA side, probably know that she leads the UCLA Psychiatry Residency Research Track. Her work's on inflammatory, oxidative, and neuroimmune mechanisms underlying psychotic disorders, and strategies for improving these particular problems. She is a recent recipient of a VA Merit Award. That's an R01 equivalent that's examining synaptic density and sensory processing in veterans with schizophrenia. Dr. Marder, Stephen Marder, is a distinguished professor in psychiatry, and he's director of the UCLA section on psychosis. He's also at the VA side director of the Vision 22 MIREC, or Mental Illness Research, Education, and Clinical Center. Dr. Marder, perhaps more than anyone else I know, has devoted his entire career to improving the lives of individuals with psychotic disorders, particularly schizophrenia. He uses a combination of pharmacological, psychosocial, and rehabilitation approaches to improve functioning. He's won numerous awards, including the Exemplary Psychiatrist Award from the National Alliance for the Mentally Ill, the Stanley Dean Research Award, American College of Psychiatry, Alexander Gronick Award from the APA. Notably, he won the Lieber Prize for Schizophrenia Research from the Brain and Behavior Research Foundation, which is often considered the top prize for schizophrenia research. So they're going to be taking the Grand Rounds on a journey that actually is refreshingly ambitious and new, because for many years, the discussions about new treatments, psychopharmacological treatments for schizophrenia, were getting slightly repetitive. That is not the case anymore, as a number of new approaches have developed, and they go beyond the dopamine blockade. So at this point, I'd like to introduce the speakers and have them start their presentation.
Michael, thank you. And I'm very glad to be talking about something very positive in the world during these very bleak times. Actually, we're what I think is an inflection point where the drug treatment of schizophrenia is likely to improve in a fundamental way during the coming decade. It's not just the introduction of the first non-dopamine blocking antipsychotic. It's the fact that it presages a time when there are going to be new drugs, new energy in drug development in different mechanisms, which won't have the sort of disadvantages of the old ones. These are my disclosures, and I should mention that I will be talking about drugs where I've actually been a consultant. Read it carefully. I'm also the editor for Psychosis for Up to Date and the editor-in-chief of Schizophrenia American. And Yvonne's. So what we're going to talk about are new antipsychotics that aren't dopamine blockers. I'm going to talk mostly about the muscarinic drugs, but and Yvonne will talk about those also in more detail with regard to the mechanisms. I'll talk about the trace amine receptor agonists, and I'm going to talk about another drug that's a sigma agonist. I'm going to also talk about drugs that aren't antipsychotic, but they don't include dopamine blockade, and it's a drug for treatment-resistant schizophrenia. And that'll be followed by Yvonne talking about the mechanism of action of these non-dopamine blocking medications. And then I'll conclude. The obviously I've been around a long time. The first author publication that I ever had was in the Archives of General Psychiatry in 1979. And it was an article about predicting drug-free improvement in people with schizophrenia. This was a study that I did at the NIMH Clinical Center, where we would take people who were on an antipsychotic, and we would take them off their medication, and a high proportion of them got better. And during these first few weeks, they sort of became more expressive, they became more alive, they felt like they were themselves, and then they relapsed. But it taught me that there was a burden to the antipsychotic drugs. This led to studies that I did with my late colleague Ted Van Putten during the 70s and 80s on ways to reduce the burden of dopamine blocking drugs by reducing doses and being much more sensitive to side effects. I had thought that after the new generation of antipsychotics came out, and we on our unit were studying all of them during their early phase 2 trials, that there was going to be a real change. And there wasn't, sadly. That those drugs, although they were incremental improvements and made patients less miserable than the other drugs, they still had this liability because they were all working for the same dopamine blocking mechanism, which is, as I'll try to say, problematic. So what I'm going to talk about is a new strategy which doesn't include dopamine blockade. And this is based on a sort of a revised understanding of dopamine and its role in psychosis. It's the idea, and Yvonne will present this more in greater detail than I. The current understanding sort of gets away from the dopamine receptor as being the problem and indicates that hyperactive dopamine transmission in mesolimbic and striatal dopamine rich areas underlie positive symptoms, and that these are actually regulated from above in other parts of the brain. So what's wrong in schizophrenia isn't really at the level of dopamine, but it's a dopamine regulation. Therefore, there are alternative ways to normalize hyperactive dopamine transmission without occupying the receptor. And I'm going to talk in detail about activating muscarinic receptors, both M4 and M1, reducing the firing of VTA dopamine neurons with TAR1 agonists, normalizing the activity of hyperactive hippocampal glutamate neurons, and modulating glutamate by antagonizing sigma-2 receptors. So what's wrong with the current way that we use drugs and that we treat people with dopamine blockers? It's the cost. A substantial proportion of patients don't respond to these drugs. They have neurological side effects, including EPS and tardive dyskinesia. These drugs change dopamine receptors, sometimes in rather permanent ways, when they cause tardive dyskinesia, and perhaps they change the course of the illness. And of course, they cause diabetes and obesity. Our clinic at UCLA, we're also kind of a diabetes and obesity clinic, because that's partly related to the illness, but partly it's the cost of these drugs which actually make these side effects worse. And there are subjective side effects to antipsychotics. They cause dysphorias. Sometimes in patients, they cause depressed mood. The extrapyramidal side effects can actually depress mood. And finally, and this is the one I want to emphasize, that the effects of antipsychotic dopamine blockers on motivation isn't a side effect. It's something intrinsic to dopamine blockade. That is, that if you use rodents or humans, you find that the kind of motivated behavior that people practice in order for social behaviors, for obtaining rewards, are attenuated, where rewards lose their value, and some of the sweetness of life can be taken away by these drugs. And that's why I believe that they're probably the most unpopular drugs in medicine. Patients don't feel better in taking antipsychotics. So, and we never talk to patients about this. And in fact, I have an editorial coming out in JAMA Psychiatry later this month saying that we need to be, now that there's an alternative, we need to be talking to patients about the liabilities of dopamine blockade. So on to the newer antipsychotics. So the idea that muscarinic agonists were effective for schizophrenia goes back to the 1950s when they used preclinical models. Betel nuts, which are sometimes used in Southeast Asia, have high concentrations of orexin, and they decrease the severity of positive and negative symptoms in schizophrenia. And then in 1997, Eli Lilly developed xanomeline as a drug for Alzheimer's. The thing about muscarinic agonist, it's an agonist at M1 and M4 muscarinic receptors, and it's pro-cognitive and probably makes people more motivated. And actually, it was probably effective in Alzheimer's, except for the GI side effects, which were horrible. In the early 2000s, Eli Lilly noticed that patients who were psychotic with Alzheimer's actually became less psychotic when they were treated with xanomeline. So there was a small trial in Indianapolis of xanomeline and schizophrenia, and the drug decreased psychosis, but 7 out of 10 patients vomited, and almost all of them were nauseated. So obviously this is a drug which wouldn't be marketed. This led to the development during the early 2000s, the idea of combining xanomeline with a peripheral anticholinergic. So if you could sustain xanomeline's effect on the brain and block its peripheral effect, that there might be a drug which would be acceptable to patients with schizophrenia. Thus was born what I'll call XT, which has had various names, but xanomeline trospium, I think, is the easiest for me. So this is one of the phase 3 trials, which was just published last year. And if you look at it's very simple. It's a 4-week study that compared xanomeline to placebo in acute schizophrenia. And you'll see that it improved all of these domains, which include the PANSS total, PANSS positive symptoms, PANSS negative, and the PANSS Marder factors, which I developed as a better way of measuring negative symptoms, which has actually surprisingly become used relatively commonly in these trials. And just to, what was interesting about this, if you look at the effect sizes, they're very large. For those of you unfamiliar with effect sizes, it's the percent of a standard deviation, and an effect size of about 0.6 is really much higher than we get with any schizophrenia trials recently, or antidepressant trials, or almost any trials. So the effect was robust for almost all of these domains, which, I think is quite exciting. But the drug, as expected in acute trials, did cause some GI effects. You'll see that if you look at the percentages, about 14% of patients vomited, almost 20% were nauseated. Others got constipated because of the anticholinergic effect of the trospium. And that's what we're finding as we administer it. In our psychosis clinic, where we've given it to a few people, we've developed all of these sort of methods, but the nausea and vomiting early on is a problem. But as I'll show, it seems that many patients, if not most, get used to it. And the effects of XT are generally sustained. And again, this is another industry figure, which shows it takes that short-term placebo-controlled trials, and then everybody gets XT, and you'll see that people continue to improve. So it's not just an effect in acute schizophrenia, it's sustained. And in that trial, when you look at the proportion of patients who couldn't tolerate it, it became relatively low. As you'll see, that only about 3% had to have their dose of XT reduced because of nausea. And that seems to be what we found in our clinic. And as I kind of interrogated every clinician I know who's prescribing it, they're finding the same thing. If they could get through those first few weeks with a very slow titration, the drug seems to work. And people lose weight on it. This is, if you look at the black line, it's people who had a BMI greater than 30, and they tended to lose weight. We hope that's not just because they feel nauseated most of the time. So there have been a number of post hoc studies, and these aren't ideal studies, but we have so little information about this drug, except from these placebo-controlled double-blind studies, which is somewhat annoying. But because these drugs should be pro-cognitive, when they did a post hoc analysis, those patients who had cognitive impairment showed improved cognition. In another study, they looked at those who had prominent negative symptoms using the Marder factors, and they found that the patients improved. There are things we don't know about the drug. It's not been compared to another antipsychotic. Drug companies don't have a lot of reason to do that from a marketing standpoint. For us in the field, that's kind of critical. We don't know how it compares for treatment-resistant patients. In our clinic, patients who are really treatment-resistant, we're not sure it works. I hear from some clinicians that it may, but I think the jury's out on that. We haven't done the right studies on cognition and negative symptoms. This should be in stable patients who have these impairments, and we really don't know of its effects. And we don't know how patients in the real world are going to tolerate the GI side effects. And again, whenever a drug goes out into the wild, the public, it always is more toxic than it is in clinical trials. And I think that's what we're finding with this drug. We've also learned some things about it, and I think in our clinic and others. One is don't take it with meals, because what happens is food increases the metabolism of trospium, and then they have all the bad side effects because the xanomeline is unopposed. So it should be taken at least 1 hour before a meal or 2 hours after. The initial trials moved too fast from a lower dose. And what we're doing is we're keeping people on the lowest dose, which is 50 milligrams xanomeline, 20 milligrams trospium, until the person develops tolerance to those effects. And usually the 100 milligram to 200 milligram dose will be adequate. Now, there are other observations which I don't want to sound like I'm trying to market this drug, but I'm so interested in it. But there are studies using that are qualitative that I'm a collaborator on that haven't been published yet. And they say, and this is what I'm hearing from some clinicians, that some patients talk about feeling kind of restored when they change to this medication, that they feel like they have their life back and their motivation. And the thing about the way we develop drugs, we only learn the bad things that we do. That's what we measure. But if a drug actually made you feel better, you would never know it from clinical trials because you never measure positive affects, which is, I don't understand why. But anyway, people do describe more positive affects. But again, that's really hard. I think we need carefully done double-blind studies, and hopefully the companies will do it soon. So, as I'll say later, there are a number of new muscarinics that are in development that look positive, and they're not just agonists, they're allosteric modulator, positive allosteric modulators, and some of them won't need to be combined with a peripheral anticholinergic. So this has gotten a lot of activity. There's another mechanism that I think people are very excited about. It's the trace amine receptors as targets. These are endogenous chemical messengers. They're similar to the to the catecholamine neurotransmitters, but they're in much lower concentrations, a whole 100-fold lower. But they do seem to play an important part in modulating different kinds of activity in the CNS. They're located in the limbic areas, basal ganglia, prefrontal cortex, and they seem to block the hyperactivity that can be induced by stimulants. Again, this is a model used for schizophrenia. The first of these drugs, ulotaront, was this was a very positive phase 2 study where again there was a good effect size, very exciting. And the other thing about it is it had almost no side effects. It decreases gastric emptying, which actually promotes weight loss. It's almost creepy how few side effects it seems to have, but that's the good news. In a phase 3 trial, the drug did not separate from placebo. That was a study that was done during COVID, when research studies kind of deteriorated a bit in the quality. And now it's going through another phase 3 trial, and hopefully this TAR1 agonist will come to development. Roluperidone is a drug that's an antagonist of 5-HT2A and sigma-2 receptors. And it's an antipsychotic for people with prominent negative symptoms and relatively mild positive symptoms. And it's an initial trial was positive. A more recent trial that led to an FDA submission. FDA is asking for more trials. So we're not sure about the destiny of that drug. Then I want to talk about one additional drug, which is a drug that operates on glutamate, and it sort of buffers against increasing glutamate, which has downstream effects on dopamine. This is a drug called evenamide, which was added in treatment-resistant patients on clozapine or other antipsychotics And as you could see, it's effective, and now it's in a large phase 3 trial and will be a site for this drug. So I promise to give Yvonne enough time to tell you the mechanism.
Hi, everyone. I'm so excited that we have such a great in-person attendance for Grand Rounds. Thank you, everyone, for coming in person. It's really nice. I'm going to turn this a little bit so the camera can see me, but mostly I want to talk to the people in the room. Dan, you're taking a picture. So Steve and I were joking before we were on our way over to this presentation that people could tolerate a maximum of 14 minutes of hearing about mechanisms. So I'm going to try to keep it to that. But I'll do my best. This is my favorite part, is I think thinking about mechanism and thinking about biological pathways in the brain is the most interesting and exciting part of what I do. Let's see, what are we doing in terms of moving my slides? Great. So the outline for my portion of the talk is going to be starting with neuroanatomy. Little did you know that you would get a neuroanatomy lesson during Grand Rounds, but I like having some framework for thinking about the circuitry that we talk about all the time when it comes to schizophrenia. And then I will talk a little bit about, so there's some debate about whether or not xanomeline is an allosteric modulator actually, or just a pure agonist. There's some evidence that it binds to both the orthostatic site and the allosteric site, but I'll talk about that. I have a little bit, I have a couple of figures on ulotaront and on evenamide, their mechanisms as well. But then after that, we'll go back to Steve's talk. So to start with a picture of the brain and the dopaminergic systems that we tend to think about most commonly in terms of schizophrenia, certainly. So we think about schizophrenia as deficits occurring in these brain circuits, right? So you may remember even from Stephen Stahl's books from ages ago that the mesocortical pathway, which starts at the ventral tegmental area and projects to the cortex, deficits give rise to cognitive and negative symptoms in schizophrenia. Then the mesolimbic pathway, which begins also in the VTA and projects to the nucleus accumbens of the basal ganglia. And then finally, the nigrostriatal pathway is one that we think of when it's triggered by, this is not advancing, guys, there we go. It's when it's triggered by dopamine blockers that it gives rise to extrapyramidal side effects. So I have been talking about this type of diagram about schizophrenia for I don't know how many years, and the history of it predates my involvement in schizophrenia research. But I found myself when I was making this presentation wanting more framework to really understand. Otherwise, these words can be a little bit meaningless, like what is mesocortical, what is mesolimbic. So I'm going to start. Oh, sorry guys, I got ahead of myself. The overall hypotheses of what goes wrong in schizophrenia in terms of these circuits is that of course, that there's too much dopamine in the midbrain, right? So there's too much dopamine both in the limbic system and the basal ganglia system, and there's actually hypofunction of glutamatergic receptors in the cortex. And so this kind of combination is what we get. And all our D2 blockers that we've had prior to these non-dopaminergic drugs do help reduce dopaminergic signaling in the midbrain. So here is the structure I wanted to share with you guys. So we'll start with a brain, and the framework that I wanted to provide is an evolutionary framework. And I think it's fairly well accepted at this point that the core of the brain evolved before the layers that were then evolved on top of it, right? We did not inherit our midbrain from lizards. That is apocryphal. That was a theory that was put forth in the 80s that's been debunked. But we did have these parts of our brain evolve from very early on. So what is this? It's an egg-shaped round structure in the middle of the brain. It's one of our oldest structures, is the thalamus. So the thalamus was responsible for input. So in early evolution, and it co-evolved with the basal ganglia. And I'm always fascinated by these diagrams because these are some bizarre looking structures, right? I mean, these are very weird. But so these two structures evolved together to give us basically input output. And then they are thought to have evolved about 500 million years ago. So these structures are present in all vertebrates, all chordates, right? So the basal ganglia is complex. It has a lot of different substructures that are connected to each other very tightly, which is why they're thought to be one sort of organ in the brain, including the striatum, which is made up of the caudate and the putamen. So the caudate is this long tail part, and the putamen is this round egg, like other egg-shaped part. The ventral striatum is here in the front. It's kind of the joining area between the two. We also call it the nucleus accumbens, and then there's a few others, including the substantia nigra, which is over here somewhere. Sorry, guys. But really importantly, when we talk about basal ganglia, we talk about the limbic system, there's things that overlap, and it's sort of like, oh, how do these relate to each other? So I really wanted to use AI to make a video that layered these parts of the brain on top of each other. It's a really beautiful way. Could not do that. Somebody needs to invite me to Sora too, please, if you're out there, send me an invite. But I tried to just from the internet cull from different images. So I'm overlaying now the next evolutionary step of the brain, which is the limbic system. And the limbic system is really important. It not only we think of it now simplistically as a reward and motivation, but actually what it does is that instead of having a what is this paradigm here? Instead of having a reflexive input and then output and response, the limbic system helps us decide which output gives me the best outcome that in responding to a particular input, right? So the limbic system, the reward system, was really important for basically starting to differentiate what kind of outputs give us the best result. And of course, from reward comes motivation. So these fundamental systems that evolved in humans, and the parts of the limbic system are amygdala, hippocampus, cingulate gyrus, which is part of the cerebral cortex, hypothalamus, and then part of the anterior thalamic nuclei as well, and then a few other structures too, but these are kind of the primary ones. But I also want to highlight in purple, the limbic system. I'm having trouble advancing slides, guys. Okay, so I've highlighted in purple here the nucleus accumbens. Where is my arrow showing up? It is not showing up. Okay, so here the nucleus accumbens, which is part of the basal ganglia, is considered to be part of the limbic system as well. So this is kind of like what there's a couple other parts of the basal ganglia that are also part of the limbic system, but we really think of this as the main junction between the two, the main overlap, along with the ventral tegmental area. So the VTA is in the brainstem, but it evolved in parallel to the limbic system, and it connects, has a lot of connection between both the basal ganglia and the limbic system. And we think of this as one of the core areas that's that has problems in schizophrenia, right? Now, we don't want to forget about the cortex, right? So this is the part of our brain, especially the prefrontal cortex, that really makes us human. It's all of our inhibitory signaling, it's all of our executive function, it's all of our abstract thinking, and that's this front area of the brain. And what's really cool is that the VTA actually evolved projections as well. Oh, sorry, guys. Yes, okay. The VTA actually evolved projections from that brainstem area to this new part of the brain, and those are called the mesocortical pathway. But then just laying on the pathways I showed you in that earlier simplistic slide onto this sort of three-dimensional, more evolutionarily informed sort of concept of the brain. We also have the mesolimbic pathway. So that's the VTA projecting to the nucleus accumbens, but we call it mesolimbic because nucleus accumbens is part of the limbic system, even though it's part of the basal ganglia. And then finally, the nigrostriatal pathway, which gives rise to those motor effects, is here from the substantia nigra over to the striatum. Okay, so I'm going to move on to talking about individual. I'm going to move on to talk about individual mechanisms of drugs, starting with the muscarinic agonists. So when I was in medical school, I learned this phrase: mad as a hatter, blind as a bat, red as a beet, hot as a hair, and dry as a bone. And that was a result of anticholinergic toxicity, right? So from long, long ago, there was an association between the cholinergic system and not just confusion, but also hallucinations and delusions. So as Steve was saying, muscarinic agents have been around a long time, and just a little bit of recap of what he was saying. So the first clinical efficacy for psychosis was unexpected and observed during this treatment development for Alzheimer's, which I also want to point out, I think the antipsychotic effect of what we know now is our antipsychotics, like Haldol, those were also serendipitously discovered because they were developed as anesthetics, right? And then, so it's just speaks to the development of drugs and mental health. So Of course, like Steve mentioned, the clinical utility was hindered by poor tolerability due to these side effects. And in the literature that I was reading, it talked about sort of two major approaches to improve the tolerability of muscarinic agonists. One is what Steve mentioned, to try to get specificity for M1 and M4 receptor subtypes. So muscarinic receptors have 5 subtypes, M1 through M5, and M2 and M3 were found to be more associated with side effects, whereas M1 and M4 were thought to be more specific for the positive clinical effect. And what's great is that if you target binding sites outside the ligand pocket, so outside the orthostatic pocket of the receptor, you can improve specificity. If you're designing a drug that only binds the orthostatic pocket, it can be more difficult to have specificity for specific subtypes. But these binding areas on the outside of the pocket can help you identify specificity. And then, of course, there's this brilliant combination of the peripheral anticholinergic combined with the CNS penetrant muscarinic agonist, which is in our case the case of Semel. So just to talk about allosteric modulators, so I'm using a classical example back to the NMDA receptor, for instance. So glutamate binds NMDA and allows cations to pass through as the channel, but glycine is a really well-known co-agonist that's been explored a lot in antipsychotic drug development for schizophrenia. And glycine is a type of allosteric modulator. So in vitro studies, when glycine is bound to the NMDA receptor, it increases the permeability of the pore to cations by about 20-fold. So you can see why it was sort of like pursued. It was thought to be a really exciting avenue for improving glutamatergic hypofunction in the prefrontal cortex in schizophrenia. But similarly, this is an M2 ribbon diagram of the M2 muscarinic receptor, for instance. You can see that there's two different sites. One is the orthosteric binding, and then the other is the allosteric binding. So where does xanomeline have its effect? And primarily, oh, these animations did not come through, did they? So it's expressed primarily, actually, M4 receptors are primarily expressed in this new structure that I'm introducing, which is the lateral dorsal tegmental nucleus, which is even further down in the brainstem. So the muscarinic subtype, so M4 modulation causes this negative feedback loop, and it reduces acetylcholine release onto the VTA dopaminergic neurons, which actually results in decreased dopaminergic signaling in the nucleus accumbens. So, oh gosh, that's too bad. I had some I also wanted to point out that the signaling for the signaling effects of this M4 agonist do not seem to affect the substantia nigra. So that's why we don't have any of the motor effects that we see with direct dopamine blockade, right? So, and this gets to the idea that Steve was talking about, which is that we're moving beyond the idea of just trying to affect dopamine levels. We're actually trying to affect the circuit. We're tuning the circuit better, and we're affecting the things that regulate dopamine as opposed to just affecting dopamine itself. Then there's also evidence that there are M1 receptors in the frontal cortex, and that they actually stimulate inhibitory GABAergic neurons to reduce excitability of dopaminergic neurons in the VT. Okay, so let's talk now about TAAR1 agonists. Not working. So trace amines are byproducts of catabolism of neurotransmitters, including dopamine and serotonin. So these trace amines just kind of like hang around in the tissue, but they're at such low doses that for a long time people thought that they didn't have a physiological effect. But then the TAAR1 receptor, the trace amine associated receptor TAAR1 was discovered, and it actually has many putative mechanisms. So one thing that it's known to do is actually heterodimerize with the D2 receptor, which is pretty cool. And then it actually reduces transmission, the dopaminergic transmission through that. And it's thought to be on the presynaptic side when it does that. But TAAR1 actually has a lot of different second messenger systems that it triggers. So this is one of like 5 things that it could be doing. And then it also has interaction with both glutamate and serotonin as well. One caveat of this, I mean, we already see clinical effects as Steve showed the data for, but in terms of like what we know about TAAR1, Most of what we know in terms of where its expression comes from the rat. We actually don't even know. There's no TAR1 like PET tracer as of now, so we don't know where the receptors are expressed in the brain in people so far. But in the rodent, they are expressed both in the substantia nigra and the VTA, and also in the cerebral cortex. So the thought is that they are expressed in those similar areas in the brain. So actually kind of similar to what you saw in terms of the M4 agonist that we were just talking about. Okay. Finally, I just want to talk a little bit about evenamide. And evenamide is really interesting. There's a hypothesis put forth by Anthony Grace that though most antipsychotics have their effect in the midbrain, of course, midbrain structures aren't shown to have pathophysiological changes in schizophrenia, right? So if you think about neuroimaging studies of schizophrenia, what parts of the brain atrophy? It's the cortex, hippocampus, temporal lobe, right? DLPFC, MPFC specifically when we're talking about the prefrontal cortex. But we really don't think about midbrain structures changing or having pathological changes. And that is a really interesting point. And so there's this hypothesis that it could be excitatory input from the hippocampus to the nucleus accumbens, increasing dopaminergic signaling onto the striatum. So what Steve mentioned in terms of evenamide is that, oh, and there's also an idea that treatment-resistant schizophrenia might have more of a glutamate predominant sort of issue than dopaminergic. And so these dopaminergic drugs don't affect the glutamatergic system in helping patients, giving rise to what we call treatment-resistant schizophrenia, but maybe it's not treatment-resistant, it's just they don't have the right treatment yet, right? So the hypothesis is that there's actually a higher level control of dopamine signaling in the midbrain coming from the hippocampus. And I want to share with you some of the, this is from rat brain, but it's actually kind of cool. So evenamide is a selective voltage gated sodium channel modulator. And what's so you know, there aren't that many drugs that we have that are affecting actual like sodium channels. Like when we think about sodium channels, we think about like cardiac drugs, right? So but what's really neat about this drug, and this is a busy slide, so it looks like it's doubled because they actually separated out male animals from female animals. And what you see, what the thing that makes evenamide really special is that you don't see any. Okay, so I have to back up and explain. MAM is a developmental model for schizophrenia. You might be familiar that in a lot of rodent models involve injecting something that causes inflammation in utero while the dams are pregnant, and then the animals that are born tend to have different firing um, uh, uh, behaviors of their neurons, and also different behavioral sort of like poor social relationships and things like freezing and prepulse inhibition and things like that. So this is now in the animal world of rodent models of schizophrenia. Anyway, in this model, what you see is that evenamide, which is abbreviated to Eve here, doesn't affect constitutive firing. So when the firing rate of neurons is not altered, it doesn't reduce firing, but it does reduce firing in the case of the animal model where neuronal firing of pyramidal neurons is increased. Um, so uh, so Steve and I are involved in a clinical trial of this right now. It's actually about to get off the ground, and it's really exciting. This will be the first time that there's a drug targeting a sodium channel, targeting the hippocampus, and hopefully avoiding a lot of the side effects associated with these direct D2 blockers. Okay, so xanomeline reduces dopaminergic signaling from the VTA via stimulation of muscarinic receptors in the LTN. The TAR1 agonist ulotaront probably has a mostly presynaptic action on D2, but it also could be other neurotransmitter systems. And then the glutamate modulator, evenamide, could normalize top-down glutamate regulation of midbrain dopamine from the hippocampus. What I think is interesting about this is I think it's really an open question whether or not all pharmaceuticals converge on dopamine to treat schizophrenia, right? Like, is dopamine the final pathway to schizophrenia, or is there something that we're really missing? Like, and I think that's still an open question. That's going to be really interesting to see what the data looks like over the next 10, 15, 20 years. And I, of course, want to just mention a lot of caveats. I've shown you a lot of diagrams and a lot of schematics, but I always say, you residents in this room will be familiar when I lecture on neuropsychopharmacology. A lot of what we're talking about is really just stories that we tell ourselves that help us feel like we know what's really happening. But ultimately, we have very little idea about what's really happening in the brain because it's so incredibly complex. And we're so limited in terms of our tools, right? But that being said, it's still really exciting that we're making progress in terms of new drugs being developed and coming to market. And it's a really exciting time to be a psychiatrist. I'm going to hand it back over to Steve.
Thanks. So just looking at the future, just the idea that the XT is just the beginning, I believe, that it's the first in class of a new generation of muscarinic drugs for psychosis, which are in development and hopefully will be available soon. Ulotaront, which had a very strong phase 2 signal. So I suspect it's an active drug, is now in a large phase 3 trial. They're in the middle of the trial and it should read out relatively soon. And I think we're hopefully in a new era of drug development where we'll have other drugs that don't block dopamine receptors, and we'll see this past 50 years as being something that we wish we had done better, because we missed opportunities during that time. Anyway, thank you for coming. Thanks for listening.
Steve and Yvonne, thank you so much. Let's see, we do have a couple questions in the Q&A, but Sabrina, are there questions in the room?
Thank you guys so much. This is great talk. I had a question about your thought, not for schizophrenia, to go over the tangent, but given the benefits of XT, what do you think about its potential to be used for people who are suffering from motivation and depression, or the mood stabilizer in general?
Ooh. I think the other thing that XT might work is Alzheimer's, particularly as where it's pro-cognitive and particularly psychosis in Alzheimer's. But that's not your question. Because it's probably pro-cognitive, and whether or not it would have a use in just regular cognitive disorders is sort of unclear. And again, you're right. It would be great to have drugs that would promote motivation. And again, it hasn't been tried. So that's a very wishy-washy answer.
I guess can I replace my offer of stimulants for some MDD patients with a very off-label style of XT?
If they can tolerate the nausea.
Yes, thank you. Any other questions from the audience?
Should I read? We have a couple.
Take the ones from Zoom.
Okay, thank you. So a couple from Michael Agress. Any role for varenicline? That's the first question.
Ooh. So varenicline, which is a nicotinic antagonist, now before beta-2 nicotinic antagonist, I think. So something like that. It's used for smoking withdrawal. And initially the thought was that it would make schizophrenia worse, and there were initial reports that it caused psychosis, and that led FDA to look into it carefully. And it didn't. I don't think there's any evidence that it has either effective or not. It was tried in trials for cognitive impairment in schizophrenia, and I don't think any of those trials were successful. I think it's the wrong nicotinic receptor that it's aimed at.
The second part of this question is cost of XT, especially for homeless and psychotic.
Yeah, I don't know what the latest cost is. I don't know. We looked into it, it was a lot. And unaffordable without insurance. In our clinic, we had some luck in getting it. The problem is with the new drug, it gets to the wrong people. There's very little evidence that it's a drug for treatment refractory schizophrenia. And in general, companies only approve it if you find that it, patients had trials and they failed. But the right person for XT, I believe, is someone who's a good dopamine blocker responder, but they feel miserable and they have this burden of blockade. And that's been, my reaction from talking to some clinicians, that the change in the patient feels this kind of liberation from the either dopamine blockade or the direct effect of the drug.
We have a couple of other questions. This one, should I go ahead, or is there anything in the room?
No, yeah.
Okay. This is from Timothy Hall. He says slightly tangential, which of course is completely fine with us. What is your assessment several years in now of the last generation of, he uses the term semi-novel antipsychotics affecting different dopamine pathways along with serotonin, cariprazine and lumateperone? I can't pronounce that second one. What's their role now?
Answer that, or I can.
Well, we love cariprazine. It's definitely shown some effects for negative symptoms in our patients. I find it more tolerable for patients. We've had a few cases where people didn't do well on other D2 receptor blockers. So I think there's a lot to be said for the partial agonists. Yeah. Lumateperone, I wouldn't say, I actually don't use it. So Steve, I don't know if you have.
It's a, it has less side, it's an incremental improvement. It's really, it has, similar mechanism to the other antipsychotics, and it had a very difficult path even getting approved. And in our experience, it seems to be a good drug for patients with weight gain, and EPS is kind of minimal. But I think it's an incremental improvement rather than dramatic.
Thanks for the question, Kid.
We have another Ralph Keck. If that's, I apologize if that's not the correct pronunciation.
Yes.
Cook.
Okay.
Hi, Ralph.
I can read it, or if Ralph, is Ralph in the room, or?
No.
Okay. You mentioned that XT hasn't been compared to another antipsychotic. That's actually a really important point that I was wondering if we'd come back to. Should we still be comparing new agents to placebo in acute schizophrenia when we know so well that DA antagonists reduce acute, I think it's acute schizophrenia, I think is the end of it.
Well, if you're a drug company and your main purpose is to get a drug approved, the easiest way to do it is to include just a placebo. We always ask them to have a positive comparator. So it would be a study where you would have the drug, a placebo, and then you would have, say, risperidone or another commonly used antipsychotic. And that way someone could read the results of the trial and get an idea about whether or not this drug is really innovative. And unfortunately, this drug was developed by Karuna, which was a relatively small company developed this drug, I believe. And they did it the fastest, least expensive way, unfortunately. And Michael and I are actually proposing a much better study to the company. And we suspect that they're not going to fund it. We're trying, we've had a couple of meetings already.
Yeah.
Yes, wow, wow.
Sorry, just one more question, because I have a 12 o'clock patient. So when you talk about the evenamide in its, do you think there's overlap with how clozapine works, given its effect on glutamate system? And then sort of related, are we concerned about cardiac side effects?
You want to take that? I'm not sure about cardiac side effects. I don't. Yeah, the only side in the studies there was concern with like one seizure or something like that, which was later found not to be related. So I think it looks relatively good, and I don't think that the mechanism would necessarily was it.
Wasn't sure about the sodium channels.
We have one more. Can we take one more question here?
Sure.
Okay, this is Diane Lee Luxembourg. The question is, given the lack of response, and then there's parentheses, or equivalent for placebo and in other studies, does physical activity, walking, running, sports, ever differentiate those who respond better given the evolution of human brain / activity and doing less work now? So a more speculative question there.
You want to answer that?
Sorry, guys, I was trying to figure out if the audience can see us on the camera. I got distracted.
Well, you know, the thing is, exercise promotes plasticity in the brain. It's a relatively strong effect. So if your idea was not just to decrease symptoms, but to have the brain do some rewiring to cortical plasticity, I think you would think that combining a drug with exercise would probably be effective. And I know that the aftercare program, Keith Netraline's group is studying that, and exercise is probably a positive promoter of illness recovery. I don't know if that answers the question. Close as I can get.
Yeah, and I think it's good to mention that, yeah, much of this work is being done at UCLA at the aftercare program. That's our last question, other than Ralph Cook thanking you for the insights, Steve. And it brings us to the top of the hour. So I think what I'd like to do is thank Steve and Yvonne for a very clear, very stimulating, and really it's exciting to be at this phase when there's so many new and positive developments occurring. So thanks to both of you for a really excellent Grand Rounds presentation. Thank you.
Thanks, Michael. Thanks for watching.
Thank you.